So I think all of you must have been aware that there was a recent increase or surge of multiple cases in Pune of GBS, and I think it was covered in the newspapers in India as well as even in the BBC news broadcast and also in the Lancet. If one third of patients of GBS develop respiratory failure, which is life-threatening, they have to be managed in ICU, intubated, and given mechanical ventilation. And we'll cover the basic questions: when to suspect GBS, how to diagnose GBS, what are differentials that you should not miss? Are there ways by which we can know early whether this patient would have mild disease, this patient would have severe disease, and like how would the patient be at 6 months or 9 months or 1 year? The purest or the old physicians, like if you, my teachers and all, like in the 1980s, they used to call it Landry syndrome, Landry Guillain-Barré syndrome, so not GBS. So the purists would not like that we only call it GBS because Landry was the first person who described this in 1859.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Guillain-Barré syndrome, or what we commonly call as GB syndrome. So why? I think so. Simon Sinek says that whenever you talk on something, begin with why. So why GBS? Why it is important in this setting? So I think all of you must have been aware that there was a recent increase or surge of multiple cases in Pune of GBS, and I think it was covered in the newspapers in India as well as even in the BBC news broadcast and also in the Lancet. If you all read journals on the this month's Lancet, there is a world report about India facing a major Guillain-Barré syndrome epidemic. So I think GBS is important for all the practitioners because it can have myriad presentations and it can have various presentations, and like it can be of mild severity to moderate severity to like life-threatening variations in presentations too. And it is important to diagnose this early because early management can improve the prognosis. So how I will go. So for I think this talk is more for clinicians like general practitioners and students. So we'll start with the history about the disease, then we'll talk about its epidemiology, what is the classic presentations, what are the different variations in presentations. And most important thing, I think we'll cover the basic questions: when to suspect GBS, how to diagnose GBS, what are differentials that you should not miss when we diagnose or considering GBS among the differentials, what is the acute care and what is the long term care, and like are there ways by which, when, as I say, that it can be mild to moderate to severe, are there ways by which we can know early whether this patient would have mild disease, this patient would have severe disease, and like how would the patient be at 6 months or 9 months or 1 year? So I think we'll cover these things in today's talk. So if we come to history, so I think though we call the syndrome as GB syndrome, I think the first description of such a ascending paralysis was actually given much earlier in 1859 by Jean-Baptiste Octave Landry. So like the purest or the old physicians, like if you, my teachers and all, like in the 1980s, they used to call it Landry syndrome, Landry Guillain-Barré syndrome, so not GBS. So the purists would not like that we only call it GBS because Landry was the first person who described this in 1859. So what he found was he had 5 own cases, and 5 of the patients were said that he had heard about them from his friends and colleagues, and he had collected and written about these 10 cases. And most of them, like if you see their descriptions and if you read it, they all have classic presentations of the classic variant of GBS. So the patient will start having distal sensory tingling sensation, and then they would have ascending weakness from lower limb up the upper limbs, and patient would have respiratory failure leading to death. And he was also at that time had described that these generally would occur about 2 to 3 weeks after a flu-like illness. So that is about Landry and his contribution. But what we know is Guillain-Barré syndrome that was actually published as in 1916. So I put a photograph Guillain and Barré. So they were two physician neurologists who were practicing in France. And before GBS, they had also said two different things also that they had published. So Guillain has a localized patient with hand weakness, that there is a brachial plexus which comes out from the spinal cord and it brings nerves to the upper limb, and a lesion in the brachial plexus, especially in soldiers like in warfare and all, would lead to isolated lower upper limb weakness. So he had even described that. And Bare, we know, we all know a sign called pruritus drift. So like when a patient has mild weakness and we raise the hand forward, the one which has pyramidal weakness will have mild pruritus drift. So that pruritus drift that we all commonly use actually was coined by Barre, and he had called it Barre's sign. But why it is called Guillain-Barré syndrome is when they published these two patients, soldiers who had this after war injury, they called it our syndrome, and because of that, then people like started talking about that our syndrome as Guillain-Barré syndrome. And they also demonstrated that in the CSF there is albinocytosis dissociation. So what we mean by albinocytosis dissociation is if you do a cerebrospinal fluid testing, the cells would be normal and albumin would be raised. So generally with infections, what happens is that cells and albumin both will increase. But this is a para-infectious autoimmune process. So here cells are generally normal and CSF albumin would be more. And that is one way by which in the past, GB syndrome was differentiated from poliomyelitis. So if you have poliomyelitis also will be a pure motor weakness, but it will be asymmetric. And that because it is caused by poliovirus, in the acute stage, if you do a CSF would be cellular. Generally now because of the polio vaccination, now this has become rare. But in that past, these two were the prominent differential that we had to consider. And further important point is that actually they were not the two who were working together. They also had Stroll, who was not a neurologist but a physician. So Guillen and Pare published the observation together in an undistinct publication in 1916, which led to this term. But actually, Stroll was also a physician who was working on these two patients, and this has led to a lot of controversies in those times that why Stroll's name was not written in the description of GB syndrome. And then some would laugh about that GBS is not syndrome; it is GBS is Guillain-Barré and Stroll. So that is the controversy or the fun part about the history of GBS. But even like there were some descriptions of such a disease even by others like Wardrop, Dumnell, Robert Graves, and even William Osler. But they didn't do a lot of workup of these patients or like did not do much analysis of CSF or electroanagostin. So these are just believed that they had described such patients. So even as early as the period of 1800 1900, this syndrome was described. And so, like, if you look at how the disease and the science well, it evolved. So, though initially Gian and Barrett described that there is CSF alveolar dissociation, it was Hemaker and Cunningham who did a series of patients whom they found that CSF protein is consistently raised in patient with CSF, and in some of the patients who died, they did postmortem study and found that there is myelin sheath edema. So that led to the discovery that GBS syndrome occurs because of what we now call as AIDP or acute inflammatory demyelinating polyneuropathy. So the Haymaker and Conhorn described that in GBS, the pathology involves the nerve cells and the demyelination of the nerve cells leads to this problem. Subsequently, Lambert, Muller, and Widenhart, they did a lot of work on electrophysiology and found out that what are the nerve conduction abnormalities that are seen in patients with this syndrome. And Kurland in 1976 described two things that in the swine flu epidemic in that time in USA, he described that many patients after the swine flu infection they go on to develop GB syndrome. And at that time, he also reported a few patients where after giving vaccine for swine flu, some patient had GB syndrome, and that I think we can relate to about 3 years back when during the COVID pandemic, some patient after COVID also developed GB syndrome, and some patient had taken vaccine, and they like the lot of people saying that vaccine of COVID led to GBS, but that's not actually very correct, as the incidence is very like 1 in a million. So the benefits of vaccine was much more than the risk of GBS. And then till the 1985, there was not much treatment except for supportive care, and patients continued to die if they were very severe. But then the Dutch people in 1990 and the North American people in 1985, they did two excellent studies. So North American people, they started doing plasmapheresis or plasma exchange. So there was a theory that there was some antibodies that were formed in the body because of the infection that were effective in nerve cells, and like removing these antibodies would lead to improvement. So in 1985, PLEX trial of North America was the first successful trial of a therapy where GBS led to improvement. Till then, the thing that people used to do was just give physiotherapy, vitamins, and steroids. But steroids were not causing much benefit in most of the patient. Rather, some of them, because of steroid, would develop infection, and that lead to like worsening of sepsis and death. And then the Dutch people, they got this IVIG. So IVIG is IV immunoglobulin, and it is believed that it absorbs the antibodies, leading to removal of the antibodies from the blood, so the nerve cells would not be affected, leading to improvement. And though the theory or hypothesis about this molecular mimic and antibody was there, it was actually Yuki from Japan in 1990 who first discovered that there is an anti-ganglioside antibody which is developed as a reaction to some intercurrent infection, and that actually leads to the development of GB syndrome. And at that time, even in that time, people from John Hopkins University, like famous one is David Kornblath, who had been to India also and took a lot of lectures in India also for neurologists. So they described that Clostridium jejuni infection precedes a lot of patients with GBS. And subsequently, even in this Pune epidemic, what has been found is that this occurred because of this Clostridium jejuni infection leading to diarrhea and leading to the GBS. And then people say that if one therapy is effective, other therapy is effective, why don't try we to try both? So people did a plasma exchange and then gave IVIG, and then it was found that giving both doesn't help. So like it'll like the theory that if you give one antibiotic to antibiotic, will it lead to further improvement? So that this American trial of giving both plasma exchange and then giving IVIG was not beneficial. So only one has to be given. So if you look at epidemiology, it has been described from all across the world. So if you look at this paper from Lancet, which talks about epidemiology, people from all parts of the world, except if you see the blank from India, where no nationwide study on epidemiology has been done, but most of the other countries have done work on uh, the incidence and prevalence of GBS. And this is one major area of research gap where our physicians, neurologists, critical care doctors, and the community medicine people have to work on a national level to know the incidence prevalence of this disease. But what is known is it affects all ages and all nationalities. The mean age is 40, but it can happen from 1 year to 90 years. The overall incidence worldwide is 0.6 to 4 per lakh annually. So if we look by this number, 4 per lakh. So if we say we are 140 crore Indians, you can see we have more than a lakh patients every year suffering from GBS. Male is to female ratio is 3 is to C, and like half of the patients to one third of patients would say that there is a antecedent infection, that is patient would give a history of infection, either a diarrheal illness or a sore throat or upper respiratory infection that precedes the development of the GBC. So as I said, how it happens, the pathogenesis, I'll not go into much detail, but you can read further. So what happens is that there are two broad categories of GBS. One is called AIDP, another is called AMAN. So AIDP stands for acute inflammatory demyelinating polyneuropathy, where the demyelination in the myelin sheath. So if you see on the nerve cells, there is this myelin sheath. So the antibodies that are formed, they affect the myelin sheath, cause demyelination, and hence the nerve conduction get prolonged, and so the patient develops weakness. So this is slow to occur. It affects proximal muscles followed by distal muscles. So it is classically called polyradiculoneuropathy. And the other variant is AMAN variant, or called acute motor axon neuropathy. So there the antibodies affect the axon itself, not the myelin sheath. So it is distal pure motor. It starts more distal weakness and then assets. So the nerve conduction would have different patterns, but these generally occur after the third or fourth week. So in the first week, when we have to diagnose and start treatment, it is predominantly clinical. So as a neurologist and for years, we get patients who are referred to do nerve conduction in the first, like, third day or fifth day of weakness to diagnose GB syndrome. So I'll say further important point that GB syndrome is a clinical diagnosis. CSF and nerve conduction are supportive to it, but essentially the diagnosis is clinical. And the classic changes or to differentiate the types of GBS occurs after second or third week. So don't rush or don't rush to get the nerve conductions done in patient with GBS. So the important point is, how do we diagnose them? So it is entirely clinical. GB syndrome. So whenever we have a syndrome, so when we come up syndrome, it basically means that it is a group of clusters of signs and symptoms. Right. So when we say jaundice, it is not a disease, it is a syndrome, and then you can have subsequent different differentials of jaundice. Similarly, GB syndrome is a syndrome where we have rapidly progressive bilateral limb weakness with or without sensory symptoms, and there is reflexes get become absent, and it can also, from the lower limbs, upper limbs, it can also affect the face and the bulbar weakness, leading to respiratory weakness, and some variants of it present with ophthalmoplegia, that is the weakness in the movements of the eyes, and ataxia or imbalance. So these are the common presentations of GBS. So these, if you have a patient who develops rapidly progressive predominantly motor deficit which is symmetrical, and if you check reflexes and they are like low or absent, think about GPS. How do you diagnose? So diagnosis is by a list of diagnostic criteria, and important part is removing or excluding the other closed differentials that I'll come to subsequently. And then we need to do some lab tests, some blood workup, CSF, and electrophysiology or nerve conduction study to support the diagnosis. So, classic presentation is very typical. Is what is more common is AIDP. So, it generally the patient will start with some distal lower limb tingling, paresthesia, which they say they have pins and needles sensation in the lower limbs in adults. Children may, what happens sometimes is children will complain that they are having difficulty in walking. They'll say they'll have pain in the limbs and they will not walk. And sometimes if exams are there and like they have to go to school, and sometimes they, in the first 3 4 days, may it may happen that the GP or the family members may feel that children has the child has some stressor in the school, and that is why he doesn't want to go. And sometimes in the first 3 4 days people may not give importance to that symptom, that the child is having complaining of pain in the lower limb and is refusing to stand up and walk. So always have a high index of suspicion when somebody complains of lower limb tingling and weakness, which is acute. So if somebody has for 6 months, we don't consider GPS. But somebody starts to have it in 2 3 days, then always think in your radar that could this be GPS. So then classically it starts from the lower limbs, so hip muscles would get involved, then the distal muscles of the foot will get involved. So patient will have difficulty climbing stair, difficulty rising from squatting position, difficulty rising from the chair or the bed. Then he'll have difficulty in holding the chappals. The chappals may fall. He may not be able to wear chappals. And then progressing to upper limb weakness, again like difficulty raising the hands, and then difficulty using the hands for the fine activity. So you, on the history, you have to ask for both the things. And then when it starts to get further worsen, so the patient is not able to hold the neck, or the speaking is difficult, there's a nasal twang comes up, or he complains of difficulty chewing or swallowing. So they are the patient that they have to be referred to the emergency immediately. Such patient have high chances of developing respiratory weakness, and like would have life-threatening weakness, and they will require admission to the ICU. So 70% of patients also develop facial weakness. 40% will develop difficulty in swallowing, and about 5% will have a different presentation where they'll only have processing extraocular movement difficulty and imbalance, which we call the Miller-Fisher variant of GBS. But one third of patients, important point is one third of patients of GBS develop respiratory failure, which is life-threatening. They have to be managed in ICU, intubated, and given mechanical ventilation. And another important point is dysautonomia. So there is autonomic dysfunction, which is very frequent. If you check patients of GBS, you check their pulse and blood pressure in supine, sitting, and standing position, like at 1 minute, 2 minute, 5 minute. 70 to 80% of them will have autonomic dysfunction, but 10 to 20% are such severe that it can lead to malignant hypertension or cardiac arrhythmia, and that can also be life threatening. So such patient would require ICU care. So how it progresses? Generally, GBS is a story of about 4 weeks. So most of the patients, if you see, there are in this chart there are three graphs. One is the orange graph, one is the green graph, and one is the blue graph. So the blue graph is the course of the disease. So it will start gradually over 3 4 days. There will be a bit pain and tingling, and then gradually, if you see, the weakness worsens. That will worsen about 4 weeks, and then gradually over a period it will improve. So even if it is mild disease, and if you don't give any IVIG or prognosis, the milder ones who have preserved ability to walk, they can improve on it on their own also, right? And if you look at the antibodies, as the weakness worsens, you can see that the antibodies rises, and then when the antibody reduces, the weakness also improves, right? And there is a preceding infection, that the orange graph is the preceding infection that leads to the antibody formation. So that precedes the weakness. So as I said, GBS can have various presentations. The classic I already described. So if you see here, the orange lines are the motor weakness, the blue one dots are the sensory symptoms, and if you see, so the classic presentation will be motor weakness as well as sensory symptoms. That is called AIDP. Then we have pure motor or AMAN variant, and then we can have little like modified version where only patient will have paraparesis, upper limb would be preserved. This would be the milder ones. Here sometimes they may be confused as myelitis, but bladder bowel would be preserved in GBS and as a like in 95% of patients. We can also have a pharyngocervical brachial variant where instead of starting from the lower limbs, patient only develops weakness in speaking, weakness in difficulty in swallowing, and upper limb weakness, and then it gets doesn't involve the lower limbs. And very rarely patient may come, if you have like seen multiple patients, you have like 20 30 years of practice, you may remember a patient who comes with a unilateral facial weakness, and you think and they tell the patient it is Bell's palsy, and you send the patient home, and third or fourth day patient comes with a weakness in the other side, and they develop bilateral weakness, and gradually weakness in the upper limb and lower limb. So important point is, if you see each and every patient of like a Bell's palsy, like unilateral weakness of the face, remember and check all the reflexes. So if with that presentation, if you see that the knee reflex or ankle reflex also is weak, though patient has just facial weakness, tell them that you remain on close follow-up. Some patients may rare be having GBS. And we can also have pure sensory variant of GBS where just patient has bilateral tingling mass imbalance, no motor weakness. And the Miller-Fisher variant is the one which is seen in 5%, where again the diagnosis is delayed because the patient starts having extraocular movement difficulty, ptosis, double vision, and then they only have ataxia or imbalance while walking. And if you check the reflex, it will be absent. So the triad of extraocular movement affection, areflexia, and imbalance, ataxia. If you have this, consider Miller-Fisher variant of GBS, right? And very rarely, like in 2 to 4% of cases, patient may develop something called Bickel-Staff brainstem encephalitis, where you also develop loss of consciousness along with quadriplegia. So that is very rare, but a variant of GBS. So this is what I described in the graph that I showed, and this is the percentage which I already told to you. And this is the spectrum. So important point is, how do we diagnose? So we have essential criteria, we have supportive criteria, and we have supportive lab investigation. So the essential criteria: progressive weakness of upper limbs or lower limbs, absent or decreased deep tendon reflexes, and progression which doesn't happen beyond 4 weeks. So if it is beyond 4 weeks, we start say this is slowly progressing. It starts 5 weeks, 6 weeks, it continues to progress. We call it subacute uh, inflammatory demyelinating SIDP. If progress beyond 2 months, 3 months, and further, we call it CIDP. So just how the syndrome progresses. Important points are it has to be symmetrical. If it is asymmetric, think about COD or think about polio or West Nile other viruses. The sensory symptoms are present, but they are just mild, not severe as the motor weakness. And cranial now bilateral facial weakness is important, and respiratory function and the preceding history of infection, as I said, is important. So some patient may have back pain, which may make people think that there could be a spinal involvement, and sometimes people do get a spine MRI done. So if bladder boiling involved, it may be prudent to get a MRI of the spine to rule out myelitis too. And as I said, CSF and electrophil are important. CSF is important because we want to show that there are no cells, so meaning not active myelitis, and electrophil is to demonstrate that there is no involvement. But important point that you ask in each and every patient with acute ascending paralysis, they check the potassium. So if potassium is low, we are dealing with hypokalemic paralysis, which could be primary or secondary, which requires complete different management. And always ask about the history of dog bite or a vaccination, because some patients with dog bite or what we call rabies present as a dumb form of rabies. So dumb form of rabies, initially it will start with weakness in the lower limbs, then upper limbs, and then the encephalitis features will come up. So unless you don't ask this you may miss this. And I've had patients which were at other centers where they were treated as GBS, given IVIG, and subsequently developed encephalitis, altered sensorium, myoclonus, and then when a history was asked, it was found that it was rabies. And always check for hepatosplenomegaly, skin lesions, and abdominal pain or hyponatremia, because that may give a clue to porphyria, which again requires complete different treatment. And if there is frank sensory level on the trunk would suggest a spinal cord lesion. And if it is hyperreflex, again, it will suggest a CV junction anomaly or high cervical myopathy. And if it is frankly asymmetric, always think about cauda-conus syndrome involvement or thing like polio or West Nile. So these are the important clinical clues which we should remember, and the differential that you should never forget. Right? So which are the factors which are like make a suspicion that this is not GBS? So if the CSF shows more than 50 cells, if there is asymmetry, if there is bladder ball involvement, if respiratory involvement occurs on the first day, it can happen rarely with GBS, but then you will think about myasthenic crisis, snake bite, or other things. So if there is fever, ongoing fever, then think about other things. If there is hyperreflexia, think about myelopathy. Abdominal pain, think about porphyria. And if it is continuous, the weakness continues more than 4 weeks, 5 weeks, 6 weeks, then we are dealing with the acute presentation of CIDP. So this, I think, I leave this more for the neurology people. But as I said, the differentials are nerve roots, muscles, neuromuscular junctions, spinal cord, and other eye cells. And this I already discussed the features how we can differentiate this. So preceding events are very common. Infections, the commonest in about 70% of patients. Clostridium jejuni, mycoplasma are the two infections. So if diarrhea, think about C. jejuni. If respiratory tract infection, think about mycoplasma. But even CMV, EBV, HIV also can, seroconversion can present as GBS. Very rarely vaccine related. Swine flu, Zika virus, and COVID also have been described. Very rarely, patient may have a surgery or pregnancy or trauma, and that can precipitate a GBS. As I said, potassium should be checked. It should normal. CPK if muscle is being considered, but even in GBS, CPK can be mildly elevated. Always get HIV in adults who are promiscuous. Also get a VDRL checked. CSF we should do to prove that it is autoimmune phenomenon and not an acute infection. Antibodies, if you are suspecting Miller Fisher, you may do anti-GQ1B. There are other antibodies which are described, GM1, GT1, GQ1, but they should not be done except if you are doing it free under research setting, because they are like very costly and they don't help in changing the management. So CSF raised protein, normal cells, what we call albinocytosis is important. If CSF is more than 50 cells, think about HIV, seroconversion, CMV, and leptomeningeal metastasis. The management, if you say, there are two main things. One is immune therapy and other is supportive care. So if we talk about immune therapy, when do we start? So if a patient has weakness that is causing him difficult to walk more than 10 meters independently, that is an indication that he or she should receive immune therapy. If the speed of progression is fast and like by 2 3 days patient has difficulty in raising limbs, he is going to worsen or she is going to worsen. So start immune therapy. If swallowing difficulty means or respiratory involvement is there, again he has high chance of developing complications. So start immune therapies. Immune therapy, you have two options. IV immunoglobulin, the dose is zero point 0.4 gram per kilogram daily for 5 days. So total is 2 gram per kilogram over 5 days. It is easy to give but a bit costly. Plasmapheresis, that also like you can do according to the weight and over 5 sessions, 1 day apart. So IVIG would finish in 5 days. Plasma generally because we take 1 day off, so by about 10 days. The good thing is in hospitals where the Pradhan Mantri Jan Arogya Yojana is there. Government provides free of cost IV immunoglobulin to patients with GPS. So that is a in the past 3 years or years back, it was sometimes difficult for patients who cannot afford IVIG. But now under the Pradhan Mantri Yojana scheme, at hospitals where they have this cluster, these patients can receive the whole course of IVIG for free. So that is a good thing that government has done recently. But the important point to remember is, or think very important point is that IVIG or plasma is just one part of care. But the most important part is supportive care. So I'll talk about when to admit in the ward, when ICU admit is required, but important things: prevent nosocomial infections, manage comorbidities, manage if respiratory failure that requires management, prevention of DVT, eye care, giving medicines for neuropathic pain, preventing SIDH, bed sore, and then providing support to the family. We'll talk about this further, but that is very important. So when do we admit in ICU? So if there is rapid progression, there is swallowing difficulty, there is respiratory distress. So like if you see forehead sweating, the sternocleidomastoid patient has to act to breathing and there is tachypnea, and you see abdominal paradox, these are signs that this patient would going is going to need ventilatory support. So don't keep him in the ward, shift them to the ICU, and if required electively intubate. And there's a score called IGRI. So if you are like wanting to further characterize, IGRI score is easy, it is very only clinical, don't require any investigations. So calculate it like how many days to admission. So if the patient has severe weakness, you'll get admitted within 3 days, right? So that will give a high score. Is the facial muscles and bulbar muscles involved? If yes, high score. And then motor power, you do assessment by like check upper limbs, wrist flexion, forearm flexion, lower limb weakness, and according to the grade power 1, 2, 3, 4, 5 that we commonly do. So if the total score comes up more than 36 to 48, it is mild weakness. But if it is less than that, it means that it is severe. So that will give you high score. So if more than 5 score is there of figures, it is means that patient high chance of developing respiratory weakness. He'll require ICU and ventilation. Low score means that you can keep in the ward. So very easy way by which we can predict when the patient has come, what required. So as I said, this is a bit of a busy slide, more for the intensivist and the neurologist. But calculate the IGRI score. The ones in high risk, shift them to high dependence unit or ICU. The ones who have low scores, they can be managed in the ward. And then the important things, I think, what is important is what to monitor. So serially assess the muscle power, respiratory function, and swallowing function, and check the blood pressure, heart rhythm, and blood oil control. So if it is progressive, they need to be observed more carefully. Important complication that this is the most important things, because we lose patient not with the primary GBS, but these issues. So choking, swallowing difficulty, put a RAS tube in place. If there are arrhythmias, start low dose propranolol. Prevent infections, do chest physiotherapy, prevent lung infection, prevent urinary infection. If most of these PGBS don't have urinary retention, so there is no point of putting indwelling catheter. You can use diapers or in females, and in males you can give them pod to that will prevent infection. Lower limb physiotherapy is important. You can give LMWH in once a day dose to prevent DVT. They have pain, so we can treat with duloxetine, gabapentin. They may be in the ICU alone. ICU psychosis, delirium can happen. They can have depression. So then counsel them about it if needed. Therapy can be started because they are lying down. Constipation can happen. So treat that. Eyes, if not taken care, they can develop corneal ulceration and problems in the cornea. So to put artificial teardrops and close the eyes appropriately, give proper diet, prevent hyponatremia, prevent bed sores, and limb contractures. These are very, very important things. So the nurses, physiotherapists, residents, the daily round team have to take care of all these issues. This very the most important. The devil is in these days. If these things are managed well, patient would have a good outcome. And what to do? I think the same thing I have talked about it, and I think these are like basic internist job to do. So, if the patient comes, if it is less than 2 weeks into weakness, check if the patient is able to walk. You can just observe. We may not give prosthetic therapy. If patient has difficulty in walking or the other signs, I say as I said, the high scores and start immunomodulation. If the patient has come a bit late, like 2 to 4 weeks into that, generally they may have like stabilize. If stabilize, then just wait. But if still they are progressing, then give immunotherapy. Right. That is about the treatment. Important one is long term. So, how would the patient recover? So, if they have moderate weakness, did not require ventilator after giving IVIG or plasmapheresis, the disease has reached plateau, they'll ask how many days I will recover. So, we have a score for that called MIGO score. So, important point is you should tell the patient is like zero power. You can tell them you will recover. Don't give a dismal medication. It can take up to 3 years, 5 years also. The other question they'll have is, will it recur? So chance of recurrence is only 2 to 5%. Rehabilitation and physiotherapy are very important, and they are essential part of the care. So the ego is so if a patient wants to know when, like what are the chances that I will recover late, so you look at what is the age, was there history of diarrhea, and the motor sum score that we already calculated. So if the score is 0 to 12, he has low risk that he will not walk independently 6 months. If the score is 9 to 12, that half of such patient would be still needing a walker or a wheelchair up to 6 months. But important point is even they also had 1 year, 2 year, 3 year, they also recover if the contractures and bed sores and other secondary things are prevented. And that is the importance of rehabilitation. So physiotherapy, all range of motion exercise important, stationary cycling, walking and strengthening important. Once they start improving, most of the patient, 91 will say about fatigue. So teach them a graded supervised motivation exercise program. We can give duloxetine is a good drug to take care of fatigue. They'll have pain in the back, lower back, limbs. They may have tingling numbness, joint pain, radicular pain. So tell them to exercise, mobilize. That helps in reducing pain. Medicines like duloxetine, gabapentin, pregabalin, and SOS basis tramadol will help. Some of the pain also would be as a part of depression, anxiety. So educational cognitive behavioral therapy, calling a psychologist and getting a psychiatric consultation to help them come out of this important. And sometimes, like when I have been to the Western countries for fellowships or observational studies, the patients there are very easy to use a walker or a splint or a wheelchair. But somehow in India, there is a stigma about using, like if a patient has foot drop, they can easily start working if they are provided foot drop orthosis or a splint, or they use a walker or sticks and aids to improve. So encourage the patient use. Sometimes even like GPs or physiotherapists may say they don't use it, आदत हो जाएगी. So it is not like that. Power is going to improve gradually, but if you use orthosis, they will help improve the quality of life. So never have a stigma to use it. So to summarize, I think it is acute symmetric ascending sensory motor neuropathy. If it is AIDP radiculoneuropathy, CSF cells would be normal, CSF protein would be raised, electrophysiology would be abnormal, but that is after 10 to 15 days. In the first 3 5 days, nerve conduction will not help. Diagnosis is clinical. Important point is ruling out the other differentials, as I said, hypokalemia, rabies, myelitis, and porphyria. Those should be improved. It is important to identify early which patient will have respiratory dysfunction. Clinically, we can know it when to put the patient in ward, when in the ICU. We can determine early When required, immunotherapy has to be started early. Both IVIG and plasma are equally effective. Giving both doesn't help much. We can predict by scores that I said. Even in the severe cases who had been on ventilator, they gradually improve and become completely normal. So when they are in that first 3 weeks and they are depressed and anxious, tell them stories about patients who are improving. What I do is that when such a patient is ICU and a patient who had recovered comes for follow-up, I make it a point to tell the patient to go and visit the patient in the ICU, because he will give a history of experience of what he has felt to the patient, and that actually I have found that it helps very much to the patient. And the patients immediately when they see a patient who has improved, they start taking doing physiotherapy and supportive therapy and very nicely. So supportive therapy, nursing, residency, residence care, and is very very important. The consultant, neurologist, physician writes treatment, that is not going to help. The main thing is nursing care that is being provided in the hospital. Physiotherapy, rehabilitation are important. It is important to identify complications and manage them and prevent them. Also, talk about fatigue, psychological distress to not only the patient but the caregivers and family. It is very important part. That is a job of the doctors and the team. And sometimes the family physician or doctor can have a very good role to help out in this, because he is the one person who is like homely and known to the patients. And be aware of differentials. Often we may like miss GPS and they may be diagnosed as functional or anxious anxiety or something, and at the same time patient may have hypokalemia or dog bite or myelitis and may be misdiagnosed as GPS. So I think that is the main point that we should include. I think with this I end the talk, and I'm open to questions, and the moderators can take back. Thank you.
Thank you so much, sir, for that wonderful talk on JPS. And yes, we do have a lot of doubt coming in from our doctors, and we will be getting into that. Before taking one of the earlier questions that we had, so it is from Dr. Patel. What are the warning signs of GBS?
I think I had answers. I had already covered these points in the presentation. So I said if it is a pure motor ascending weakness, which starts from the lower limbs to upper limbs. As I said, patient will complain of acute onset tingling sensations in the lower limbs, and then difficulty climbing stair, difficulty rising from squatting position, predominantly motor with preserved bladder valve function. And if it starts from the upper limbs, then weakness, difficulty in doing shoulder movements, of lifting things from a height. If it is a like housewife, she will say that she cannot lift up things from the kitchen cabinet. Like difficulty in buttoning and buttoning, difficulty in breaking chapati and eating. So these are the symptoms that we commonly present.
So another question from Dr. Patel we had was, what is the pathophysiology of albinocytological dissociation in JPS?
So I think, as I said, what happens is there is something called molecular mimicry. So we have some antecedent infection, and our bodies produce antibodies to it. They antibodies affect the myelin sheath of the motor nerves and the radicals. So radicular neuropathy, that is what we call. So because of that, the protein in the CSF increases. But because as it is not active infection, it is only inflammation, the blood cells in the total count, white blood cell in the CSA would not rise generally less than 10 to 15. So we have raised protein and normal cells. So that is what we call albuminocytologic dissociation. Well, as this is different compared to meningitis or myelitis, where we'll have that the cells also will be in like more than 50, 100, 200, 500, and protein also will increase. So that shows that it is not active infection, but the autoimmune process, inflammatory process that leads to this disease.
Next question from Dr. Kulkarni. What is the percentage of prognosis of GB syndrome in middle age, 35 to 50 years, post thrombolytic therapy within window period without any comorbidities?
Uh, Thrombolytic therapy means with for stroke or for myocardial infection. Can the Dr. Ravindra specify? And again, this is one of the rare thing. So I think this one of the red flags. When I hear this, I need to know more details. So sometimes it may happen the patient may develop a lower limb weakness and like acutely, and maybe misdiagnosis, stroke, and given thrombolysis. If they are talking about MI, so as I sometimes rare cases are described that when they undergo a trauma surgery or even a pregnancy after post-pregnancy delivery, some patients may develop GB syndrome. But that is only 5 to 10%. I need to know what thrombolysis is talking about and was it really GBS? Sometimes thrombolytic therapy may lead to bleeding in the cord, which like in the cervicodorsal cord, and that may also lead to quadruparesis or paraparesis, and it may be misdiagnosed as GBS. So, a lot of red flags here. So, need more information.
So taking the next question from Dr. Devra, how do we differentiate between AIDP and SADP? Also, how do we treat SADP?
That is, I think, a very good question. And SIDP is not a term that actually is true. What we call is CIDP, so chronic inflammatory demyelinating polyneuropathy. So some patients with CIDP generally would start slowly. So symptoms would be the same: weakness in the lower limbs, nerve pattern involvement, motor and sensory. But it would patients would be slowly progressive. They would not come in the first 10 to 15 days. They will come at about 2 months or 2.5 months, like 6 to 8 weeks. Some patients may come at 5 to 6 weeks. So the divide that is done is more artificial. Doctors have done it. So, like if it is less than 4, we call it AIDP. If it is more than 8 weeks, we call it CIDP. Something in between. So, it's acute, not chronic. So, use the term subacute. So why this happens is some like about 10 to 15% of patients of CIDP at the onset they'll be like they'll come rapidly. So they'll come in 10 to 15 days, and because there is acute weakness, they'll for that period they'll satisfy criteria of GBS or AIDP. So they are treated with IVIG. They do initially they improve. By 4 weeks they look all right. They are discharged, and then at 5 weeks, 6 weeks, they again come up that again I'm having weakness. So that is where when we use the term SIDP, most of them would ultimately turn out to be CIDP. So CIDP has again multiple causes and differentials are there. So commonest CIDP generally would be secondary. So what we have to rule out is paraproteinemia, malignancy, HIV, seroconversion, syphilis, some that are important. Some patients with diabetes also present with CIDP. And then you can have idiopathic or autoimmune CIDP. Again, there are like 5 different presentations of CIDP with different antibodies that have been displayed, and they are again like if you this is more about like how do we treat at this. So we look at as lumpers, so we can be lumpers, lump everything together, and we can like split. So as I said, these are syndromes. So if we start splitting them, CIDP we can call it as a Lewis Sumner variant, then we can call it as a Poem syndrome, then we can call it as a anti-MAG antibody syndrome, and then these are like bit of like complex things that would require more of discussion with neurologists for individual patients. So treatment again would be immunomodulation. So here steroids would help because they are slow to progress and like the infection chances are a bit less. So you can start with steroids. You can give plasmapheresis if it is rapidly progressing or even IVIG. But here it will not be a single cycle of plasmapheresis IVIG. CIDP patient require them to be given multiple times. So you may give it for 5 days, and then some of the patient may require it like once a month part of the cycle. And now we have subcutaneous formulations for IVIG also. So if the patient doesn't want to get admitted, he can take it. The device is like pump infusion, which he can take it at home subcutaneously also. And beyond that, now because it is slow progressive, we also have immunomodulator tablets. So azathioprine, mycophenolate, mofetil, they also have a good role. And for refractory ones, rituximab can be given. And like if very refractory, in some patients, we can do a bone marrow transplant as well. And important point is paraproteinemia. Some of them may actually have monoclonal gammopathy, and which turns out to multiple myeloma. So then the therapy of myeloma would be so a lot of things.
So next question from Dr. Gopal Krishnan. So, can the patient have a single nerve or sensory involvement like the sural nerve demyelination alone as the presenting symptom?
So it will not, as I said, it is polyneuropathy, polyradicular neuropathy. So not one will be it, that will be called mononeuropathy. Right. So on the first day, if a patient comes, you will have tingling numbness in the lower limbs. But nerve conduction changes take about 3 weeks to get for a nerve. So patient may complain of tingling, but will not be sural nerve demyelination there. As I said, GBS progresses. So in neurology and in life, at what time we see a patient, the differentials, the workup change.
Next, Dr. Raghavendra asks, how often can automatic recovery happen?
So all patients they recover. Even in the past when we did not have IVIG plasmapheresis in India, that was available free of cost. Not all patients could be affordable. So in the 90s and 2000 up to 2010, when patient would not have the cost of getting plasmapheresis or IVIG, like when I was in AIMS or at Sanjay Gandhi PGI Lucknow, what we used to do is we will keep them in the ICU, intubate them, and just take care of mechanical ventilation, preventing complications, DVT, infection, pneumonia prevention. Because admission in ICU in government hospital will be free. Don't give them anything because they will not afford, and like it will not be possible such costly therapies. And at 4 to 6 weeks, most of the patients would resume the respiration, the tracheostomy would be closed, then they start chewing, swallowing, and gradually 6 months, 1 year, 2 years down the line, they all completely improve. So immunomodulation helps in decreasing the tempo or progression of the disease, and it helps in removing the antibody early so that respiratory worsening doesn't happen. And if they are on ventilator, it reduces the number of days on ventilator. It is not like a panacea that you give it and the next day patient improves. And if you go beyond I just discussed it at the basic level, if you go at advanced level, some patients once they receive IVD, they do not improve. राइट एंड देन जैसे 2 लाख का दवाई इंजेक्शन लगा दिया कोई इम्प्रूवमेंट नहीं अभी तो वेंटिलेटर पे ही है बट दे इम्प्रूव well on this that you give only single IVIG like the 5 dose and then you like give twice and in two groups people randomize them in a double blind manner and the study result was that the second dose of IVIG did not lead to any improvement. But again, if you go into the detail, there are some patients who may actually improve. So that is called what we call treatment fluctuation. So treatment fluctuation is patient is starting to start like to worsen. Patient comes at second or third day, you started IVIG. So at the when the patient had not reached its peak, you give antibodies and you suppress the antibodies. So at 15, 20 days. So by 7 days, the patient IVIG was over and the patient stabilize about like 15-20 days. 20 days again the patient's antibodies worsen and again the patient started to worsen. So in that case, IVIG may be given. So it is on an individual basis, personalized basis, and here what we call we have to take a shared decision with the patient, their condition, their affordability, and everything. And some patient may actually come up. I often get call that patient is in such and such ICU already. IV is given, not improving, and then they like shift to other hospital or they call for opinion. Important point is some of the patient actually may develop respiratory infection. So they may be given aminoglycoside antibody, antibiotic, fluoroquinolones, which are known to lead to critical illness, myoneuropathy. So on ventilator, this thing. So that the worsening actually not be there. It may be that the patient is just not being able to wean from the ventilator. So in such patient, giving a repeat dose of IVIG is not going to help. And as I said, GBS syndrome is a syndrome. So if we go electrophysiology wise and science wise, again it can be AIDP, it can be AMAN, it can be AMSAN, and it can be the Miller-Fisher variant or the anti-GQ1B. Now people have described two other syndromes, one is acute nodopathy and acute paranodopathy. So acute nodopathy and paranodopathy again have different disorders. They also have a fulminant course, or what we call the fulminant GBS course, and now there is emerging evidence that such patient may require rituximab to improve. But these are again under evaluation and as a part of personalized medicine.
So next is from Dr. Reddy. Is there any role of corticosteroids?
So, steroid is a question which people commonly ask us, and especially the senior physicians who had worked and seen patients in the 1980s and 90s, when IVIG and plasmapheresis were not easily available at all places. There have been two major trials where they compared steroids with IVIG, and what was found was that because that patient had such trials had included patients who were very sick in the ICU on ventilator, what and the studies were like very number of patients on either side was about 40 to 50, not great numbers to give good evidence. But patients on steroids had secondary infections which were not seen in IVIG, so that trial showed that IVIG is superior to steroids and that steroids may actually harm. But because of this trial, subsequently steroids have not been studied. But I remember senior neurologists, senior physicians who say that in 1995, 2000, when they were practicing, they used to give steroids in mild patients with GBS who were not on a ventilator, and they found that about after 2, 3 weeks, 4 weeks, when the patient would come, they would actually improve. But is it really the steroids or the natural course? As I showed to you, patient with mild or moderate disease, actually, once the antibodies wean off, they are itself has a course in which after third week onwards, the patient starts to improve. So, anecdotal evidence is there that steroids may lead to improvement, but problem is, and if as I said, if it is SIDP, so 5 weeks, 6 weeks, 8 weeks progression of the disease, we give treatment is steroids. Right? But if something is 2 weeks, we say steroids are not effective. The problem is the science itself doesn't have the correct answer. And the problem is if we want to do a trial, suppose trial comparing steroids and IVIG, who will fund the study? The IVIG trial was sponsored because it was the IVIG company who wanted to assess its dose. So it sponsored it. Now IVIG costs 3 lakhs, steroids cost 5 rupees. Will a company interested to do a study finance the trial like that? Universities or government can take a call to do a clinical trial randomizing patients on steroids. Right? Institutes like AIMS or some set government institutions where now under the Pradhan Mantri Yojana, IVIG therapy is free. They are the best places to do actual randomized control trial to see whether effective. But till that we cannot give it now because the legal issues and all the patient doctor trust ratio has gone to the bottom. If you, as a humanitarian resource, if you give steroids, the patient develop infection, he may sue you. So then now the newer doctors would resist giving steroids, though the older doctors still say that steroids may have a role in this condition. But so we need a scientific evidence-based answer to this.
So the next question says, is there any role of hyperbaric oxygen
No,
in
no,
GPS?
no answer. Nothing.
So next is from Dr. Swami. Can sometimes HPV infection misdiagnosed as GBS?
So there are two things. One is infection and another is syndrome. So there's nothing like misdiagnosis GB syndrome. HPV infection may have triggered an immune response which led to G. As I said, GBS syndrome is a clinical diagnosis, a syndrome of constellation of signs symptoms. So when a patient has progressive weakness in lower limbs, upper limbs, predominantly motor, normal bladder bowel, and as I said, other things are ruled out, we can see CSF flow, cytosolic dissociation, we call it GB syndrome. So I think the question is probably maybe he can rewrite the question as to what he's asking. Maybe he's asking, can this infection lead to GBS? So it is not commonly described, but HPV generally is not linked to GBS.
Dr. Palak says there were multiple cases together in Nisraya. Can the cause or etiology be found in such case?
Nisra is the Pune, that is what we are talking about. Where is Nisra? Can he type? Can she type? I
Dr.
think
Palak,
so. Actually,
yeah.
government does do this work. So NIV Pune is the center where National Institute of Biology is there. So in whenever there are epidemics at this places, government is notified, and the uh, government just start collecting the sera and CSF samples of that region. And in some of the patients, we have found it as like in the Pune thing, the C. jejuni infection has been found out as the source that led to it. But it is important that when a physician observes multiple cases in that region, he or she should inform the government at the PHC or CHC level, and the community medicine people are well trained to work into it. As this would be like if in the children, the pediatrician acute flaccid paralysis syndrome, all patients less than 14 years in India are reported to the government, and their stool samples, sera samples, and are collected, and they are worked out diligently.
So the next question says, can post snake bite cause GBS or any reported case?
Snake bite is a differential of GBA. So snake bite generally would present with acute difficulty in opening eyes to cease, and then go on to develop rapid onset uh, breathing difficulty, and subsequently leading on to ventilator. And then if you give anti-snake venom, they gradually improve. But some patients actually may develop secondary infection, and then antibiotics are given, and then they develop critical illness myoneuropathy, and sometimes they may be misdiagnosed as GPS, as I was saying earlier. So because it is predominantly motor weakness in the upper limb, lower limb, and patient may have difficulty in weaning from ventilator, so people may say it as GBS, but anything can happen in science. So if some patient after the snake bite or that venom, we give anti-snake venom, it is ultimately like an antibody, like an antigen. So if some patient may develop autoimmune process, right, and if we see predominantly pure motor weakness, CSF shows raised proteins, and nerve condition does show deviation, we may call it GBS. But we have to be diligent in labeling that this snake bite led to GBS. Could it be venom, anti-snake venom related? Could be secondary infection that happened in the ICU, lower respiratory infection or a diarrheal infection that actually led to GBS. So these will, if we'll get anecdotal evidence or reports like that, but even if you search PubMed, we will find one or two cases reported like that. But this will be great for evidence if you look at evidence on the evidence pathway.
So next is from Dr. Aditya. Is myalgia in lower limbs significant in history of GBS, and what is the approach and
Yes, so
differential?
myalgia is like many patients with GBS, once they recover, they do complain of myalgia, joint pain, nerve pain, tingling, numbness, fatigue, and it is very common. And but the approach is similar to what we do for all patients. Rule out other things, rule out joint inflammation, rule out CRP has elevated or not? Are there acute inflammatory markers, or it is just a form of first or sequelae to the GB syndrome? And as I said, patient often when they have pain, they stop exercising. So it is important to motivate them that exercise is doing full range of motion activities, graded physiotherapy rehab program would help. And yes, duloxetine, gabapentin, pregabalin are good drugs, and they need to be titrated appropriately under care of a neurologist, and they do improve.
So, another question from Dr. Aditya was, is there any role of antimicrobials?
So the diarrhea or the infection that occur actually 2 3 weeks before the onset of GBS. So before the patient comes with GBS, the patient would already have been treated with antibiotics for that infection that had happened. And sometimes it is viral infection, so antibiotics may not have. So this is not directly caused by the infection. The disease happens because of autoimmune molecular mimicry and the autoantibodies that lead to nerve injury as demyelination or as axonopathy.
So, doctors, I think most of the questions have been addressed by Sir while answering the others. So, we can just take one last question from Dr. Swami. What are the cutting edge best practices to reduce the length of stay in ICU or any advanced therapeutic regimen as longer LOS can cause more nosocomial infection?
Yeah, so I think it is not cutting edge practices, but simple things. As I said, devilizing details. So the nurses in the ICU, residents, the medical office in the ICU, the critical care physician, and that team is the most important things. Cutting edge practice would be preventing complications, detecting the complications early, and treating them right at the onset. So, avoiding antibiotics that affect the neuromuscular junction. So, avoiding aminoglycosides, avoiding fluoroquinolones, use other drugs which are safe to the nerve and nerve muscle junction. Good physiotherapy prevent lung infection, prevent bed sore, prevent DVT, prevent urinary infection. Do not put a catheter unless the patient has developed retention. Physiotherapy, preventing nerve compression because patient may lie on the bed and may develop common period nerve palsy. Prevent that. Prevent contractures in the limbs. Do good chest physiotherapy, suction properly. If the endotracheal tube remains for like 10 days or more, do a tracheostomy. Tracheostomy helps in early weaning out ventilator because it like if a patient is intubated, patient has to use more 200 around 200 ml of extra air to take in and take out. So the efforts in a weak muscle are more. So if you do a tracheostomy, that much exertion that the chest walls and respiratory muscle lungs have to use that reduces. So it helps in weaning the patient early from the ventilator. Again, doing a tracheostomy, you require patient and family to be counseled properly because they are worried that the speech may go away, but generally it comes back. So the counseling them properly is important. And we all think that when we talk of any cutting edge technology, I think simple things are more efficient, but they are the ones which are neglected. So the team has to be motivated, they have to be proactive. That is the best practice. And
So
there
just
are some
one last,
specific
yeah.
ventilatory techniques that helps in weaning and preventing lung collapse and atelectasis and preventing pneumothorax and things. But these are, I think, out of beyond the scope of the current talk. I think you can call a critical care person who can talk about mechanical ventilation practices in different neuromuscular disorders. They are important.
So just one last question that has come up a few times. Is massage therapy useful in GBS?
So massage, because some patients will have neuropathic pain, when you do a massage, there are two things which happen. One is like when we have pain somewhere and we apply a lotion. So the nerve cells which have which like thalamus and areas of the brain which have sensitization to the pain, they will have the sense of the touch and then the proprioception. So that pain center gets a bit diverted. That is the mechanism how we reflex by the reflex action. That helps. Second thing is massage. It is that if the patient's family member is or relative is giving massage, they will feel that somebody close to me is helping me. He's worried about me. That will give a sense of oxytocin release and a feeling of warmth. That would make the patient suffer a bit less. It will reduce the distress. Beyond that, it doesn't help much. I think rather than massage, the important point is full range of motion activities, graded exercise, and preventing contractures and preventing nerve pressure passes.
With
So
that,
if a patient
yeah.
relative are doing massage, so don't tell them "आहा, मत करो फालतू ऐसे मत करो." That doesn't help. But if somebody starts like a chiropractor or something starts coming to them and charges 300, 500 rupees per session, then I'll give you massage and improve. Tell them that don't fall in that trap and don't lose a lot of money on that.
With that, sir, thank you for taking in all our questions very patiently. And thank you once again for this wonderful session. This was much awaited, and can't thank you enough for doing this session with us. It was lovely to have you back on Medflix, and there's a lot of appreciation coming in from our doctors as well. Thank you once again, sir, for doing this
I
session.
think I guess there are 500 people attending. Is that true?
Yes,
Uh,
yes.
I think also. I hope the people enjoyed it, and I think that had some educational value too. I also enjoyed with this talk, and I'll be happy to be again and have some session if you plan. Thank you. This is a good work that you all are doing.
Thank you, sir. We hope we'll host you again, sir.